welcome to another episode of Well-Adjusted Mama. I'm your host, Dr. Laura Brayton, and today's guest is Dr. Melanie Howell, and we'll be speaking about hope for pelvic pain conditions. Dr. Howell grew up in Bergen County, New Jersey, and received her medical degree from the University of Medicine and Dentistry-School of Osteopathic Medicine. She then completed a residency in Physical Medicine and Rehabilitation from NYU Langone Medical Center, Rusk Institute of Rehabilitation Medicine. Upon completion of her residency, she went on to pursue fellowship training in Cancer Rehabilitation Medicine at Memorial Sloan Kettering Cancer Center, where she focused on the treatment of pain as well as restoration of function during and after cancer treatment. Dr. Howell is board certified by the American Board of Physical Medicine and Rehabilitation, a member of the New York Society of Physical Medicine and Rehabilitation, and a member of the American Osteopathic Association. She is also an active member of the American Academy of Physical Medicine and Rehabilitation. In addition to participating in a research project emphasizing the prevalence of pelvic girdle pain, she has published peer-reviewed articles in both musculoskeletal medicine and acupuncture. Dr. Howell also co-authored a pelvic pain chapter in a pain management manual. Dr. Howell joined pelvic rehabilitation medicine because she is both passionate and determined to manage the discomfort and dysfunction associated with pelvic pain. During her medical training and as an attending, she saw firsthand how debilitating this pain could be. She remains dedicated to providing this very deserving patient population with options and improved quality of life. In her spare time, Dr. Howell enjoys cooking nutritious meals and spending quality time with her husband, toddler, and newborn son. Hi, Dr. Howell. Welcome to the show. I'm very excited to have you on today.
Hello, and thank you so much for having me, Laura. Thank you.
Yeah, so I'm excited to really delve deep into this topic of pelvic pain conditions because it's something I think that impacts a lot of women and men as well. And it's really especially related to the perinatal population, which is a large part of the listening audience for Well-Adjusted Mama. And so I'm excited we've had pelvic PTs on, and we've had a vagina coach. So we've had all types of experts speaking around the pelvic floor and the importance of proper function in that area.
Right.
But you'll be the first medical doctor who really specializes in helping with chronic pelvic pain conditions. And I'm really excited for you to share your expertise.
Great. No, I'm glad to be able to discuss this with you and the audience. I actually became a pelvic rehab specialist. I'm a physiatrist through residency. It's also known as a PM&R doc. And basically that's a physician who's trained to focus on the musculoskeletal system and its pain-causing disorders. But I decided to specialize in pelvic pain really because I always found chronic pelvic pain to be very fascinating. I got exposed to it a little bit in residency. And I enjoy working with women. I definitely work with both men and women, but in my practice, I'm seeing about 75 to 80% women. And I'm also really passionate about being able to address the gap that, is in pelvic pain research and treatment. It's such a complex condition, and it can really affect a person's physical, social, and emotional well-being. Pelvic pain specialist, it's really just a huge umbrella to describe providers who treat a pain or dysfunction that's related to the pelvic region. So gynecologists, for example, they're trained to look at the reproductive system in women and look through this lens to figure out, potential causes for pelvic pain. And then a urogynecologist is looking more at the urinary tract. A physiatrist like myself, I'm going to look closely at the muscles, nerves, and joints of the pelvic region. And then I'm going to try to find potential causes for the pain. Or if I can't find them, I'll, refer them to the most appropriate specialist if I'm suspecting that the pelvic pain is coming from somewhere else.
Mm-hmm. And I really resonate with that as a chiropractor because certainly I have men and women in my practice with pelvic pain that is musculoskeletal at the cause. And that's really chiropractic can shine in that area, along with pelvic PT as well. So there's a lot we do to address alignment with the bony pelvis and the muscles that attach there and all the complex nerves, right, that are in that area as well. But I certainly have had patients that were having chronic pain and were not really responsive to non-invasive treatments like physical therapy and chiropractic. And that's where it's such a blessing. There's practitioners like yourself that can be so helpful when there's the musculoskeletal root cause of the pain, but it's not responding to these non-invasive therapies.
No, absolutely. And getting to the root cause, of course, is going to involve a very detailed history, taking interview about the patient's pain, as well as you do as well, a comprehensive musculoskeletal exam. And then I'm going to add an internal exam that's going to really assess the muscles and nerves of the pelvis.
Mm-hmm. Right. So tell me, like, what are some of the common pelvic pain disorders that you see in your practice that are like specifically, well, I guess they don't have to be specifically musculoskeletal, but things that you're treating in your practice?
Absolutely. Dyspareunia is one that I see very often. And dyspareunia is just a medical term for painful sexual intercourse. And by definition, this pain can occur before, during, or after intercourse. And statistics show that it affects about 10 to 20% of all U.S. women. And yeah, it's a huge number. And it also shows that 44.7% of women are reporting dyspareunia at 3 months postpartum, 43.4% at 6 months postpartum, 28 at 12 months postpartum, and 23% at 18 months postpartum. So it's a really prevalent issue.
Especially after giving birth.
Exactly. I mean, these numbers are kind of staggering. So dyspareunia is a huge one that I'll see. In terms of other causes of chronic pelvic pain, there's really not even enough time in this podcast to discuss them all. There's so many, but just to name a few, inadequate lubrication is one. Postpartum related dyspareunia that we just spoke of, because of birth trauma or maybe some dryness. Vaginismus is another cause of this dyspareunia, which is an involuntary contraction or spasming of the pelvic floor with entrance or penetration. Endometriosis is another, which we'll discuss. Fibroids. Sometimes it's an anatomical variation, like a retroverted uterus, which is where the uterus is tipped backwards, aiming towards the rectum. So because of all these potential causes, 9 times out of 10, I'm going to order an image or refer to my gynecology colleagues when I'm trying to tease some of this out. So when a patient comes in with the complaint of dyspareunia, I'm going to ask very specific questions, whether or not the pain is with superficial entrance or with deep penetration or both, because getting to the answers of these questions give me important clues as to what exactly the cause could be. I'm really also aware of the emotional factors that can sometimes really be involved. Sometimes sexual trauma is interplayed with these patients too and can be playing a role in their symptoms. So for treatment, in addition to medications and referral to physical therapy and injections, I'm also very often referring my patients to mental health professionals to address some of the more emotional, complexities of this. Endometriosis is another big one that I see. It's the condition that, it basically occurs when the tissue that's similar to the endometrium, which is the lining of the uterus, is found outside of the uterus. And the tissue can really be found anywhere, sometimes on fallopian tubes, on ovaries, in the rectum, on the colon. It really doesn't discriminate. And because of all the places that it can find itself, it can cause a lot of pain and dysfunction in the organs that is infiltrating. So usually affects women in their reproductive years, but it's actually been found in patients as young as 11. And it impacts 200 million women worldwide. 5.5 million women and girls suffer with this in North America alone. And the number that really, really shocks me is that it accounts for 40% of female infertility. So we don't currently have a cure, but there are researchers and clinicians working hard to change that. And the clinic that I'm working for, Pelvic Rehabilitation Medicine, we're participating in the ROSE study. That stands for Research Outsmarts Endometriosis. and it's being run by the Feinwell Institute for Medical Research out of Northwell Health. And they're actually collecting blood, preferably menstruated blood, from the participants to hopefully be able to get a better understanding of the genetic basis of the disease, as well as what might be happening on a more cellular level, so we can, be able to develop treatments and cures for it.
Wow, that's fascinating. The other thing that I would question about even those stats is I feel like endometriosis is underdiagnosed. There's a lot of women having dysmenorrhea, painful periods, and because it can be, I think the only way to diagnose this is to actually have surgery, correct?
That's the only way to definitively diagnose
it. Right. So for a lot of women who aren't doing that, don't want to do it, or haven't even known it's an option, they're having these painful periods every month, and maybe they haven't actively started trying to conceive yet, right? So fertility isn't necessarily on the top of their mind, but they're in their 20s and 30s, and it can be really debilitating every single month when they're having their period, and or not just painful periods, but also digestive issues, right? Because you mentioned the intestines can be impacted as well. So when we see that, I'm like, wow, how many? If those numbers those are high numbers of women having endometriosis, then what about the women that aren't even diagnosed?
You're so right. You're so right about that. I'm 100% sure that these numbers aren't even quite right, because I can't tell you how many patients are coming to me in their 50s and their 60s and telling me that they had just been diagnosed with endometriosis and had been having these symptoms, the painful intercourse, the heavy bleeding during menstruation, just pelvic pain for years, and had not, had seen many doctors, and had, presented with these complaints, but just unfortunately were not diagnosed until 20, 30 years, sometimes 40 years after the, initiation of their chief complaints.
Wow, that's crazy. So let's say a woman does come to your office and you suspect endometriosis. What would you recommend for her?
Sure. So oftentimes I'm actually connecting my patients with an endometriosis surgeon or GYN urogynecologist sometimes, who has the capabilities of doing a laparoscopic evaluation or surgery, so that we can actually get tissue and definitively give the patient the diagnosis of endometriosis. So a lot of times it's referring to these colleagues, and then also helping them symptomatically with their pain. So sometimes I am helping, whether it be through medication management or through injections, helping them to be able to get to a place where they're just having less symptoms, less pain. And then if they are going to get the laparoscopic surgery, helping sometimes pre-laparoscopic surgery so that their flaring and their pain wouldn't be as severe afterwards, if that makes sense.
Mm-hmm. So tell me about the injections. Like, what are they and how is that performed for the pelvic pain conditions?
Absolutely. So in my clinic, I offer these ultrasound-guided hydrodissection peripheral nerve blocks. So it's an injection where I'm using a numbing medication mixed with an anti-inflammatory medication, and I'm injecting around the nerves of the pelvic floor to try to reduce inflammation, increase blood flow, and create space in the pelvic floor. And so during this process, these nerves are getting blocked, and that blocking of the nerves is helping to both desensitize the nerves and also to reset them. So the idea is, what I'm trying to do is calm down the peripheral nervous system to address these very disorganized pain signals. And then I'm also doing some trigger point injections into the muscles of the pelvic floor at the time that I'm also injecting the medication to try to relax the muscles. I'm getting about 75% of my patients are reporting improvement, significant improvement in their chronic pelvic pain syndromes after having the series of these injections.
That's so fascinating to me. And so when we think about the nerves, we know the nerves have a sensory and a motor function to them. So these specific peripheral nerves that you're desensitizing, has that impact the motor is there any impact on that?
Well, really we're for the most part trying to target the sensory nerves. The sensory nerves are, the ones that are really giving us this very noxious, painful stimulus. And so, we're really trying to desensitize those sensory nerves with both the numbing agent and then just decrease the inflammation around the nerves. We find that many of those nerves and many of the conditions that come to us in clinic, the nerves are being compressed sometimes. Sometimes they're just being contracted or kind of pressed around contracted muscles. And so you're having a lot of spilling of these chemical pain mediators into the bloodstream. So by injecting this anti-inflammatory medication around the nerves, we're getting a lot of the decreased inflammation and trying to reset those nerves and calm down this kind of inflammatory cascade that's happening.
I love that. And I think it was, as we were speaking via email before this podcast interview, and you do see a significant amount of the population coming to you, I think, are in that chronic pain category as opposed to acute. And so I'm really interested for you to then share about chronic pain and specifically how it impacts the brain and really what that means from the nervous system perspective, because there is a difference from having like an acute injury and how the nervous system responds to then transitioning to a chronic pain cycle. And like you mentioned, even having to reset the sensory nerve function with the injections that you're doing.
Absolutely. So there's a saying, pain is brain. I used to hear that a lot during my residency. And now I know that there's so much truth to it. So for example, if you stub your toe, it feels like the pain is just in your toe when in fact it's occurring really at your brain, at the level of your brain. And that's because the way that we perceive pain is actually formed by brain circuits that are receiving inputs from the nerves that are allowing us to feel and sense things in our environment, those sensory nerves that we were just talking about. So there's a great book by a neuroscientist out of Johns Hopkins. His name is Dr. David Linden. And the book is called Touch the Science of Hand, Heart, and Mind. And it goes into all the detail of this. It's a great read. And to summarize a little bit of what's in this book, he speaks a lot about the concept of neuromodulation, which is basically the brain's ability to either amplify or turn up a signal or inversely turn it down. So scientists are starting to figure out the genetic and physiological factors that are associated with how our brain can either dial up or dial down these pain signals. But what we do know is that when the pain becomes chronic or when the body is exposed to these pain signals constantly for a period of about at least 3 months, there are actual structural and functional changes that are occurring in the brain. The chronic regional pain, there's about 20 to 25% of that in the population, and chronic widespread pain, there's about 10% in the population. But in chronic pain, there are signals that result from this abnormal or injured tissues in the periphery in your body. And then they get transmitted to a part of your brain known as the dorsal horn. And then that message then gets transferred to a region of your brain that receives the input. So now we're able to measure these changes that happen in the dorsal horn on functional MRIs, which are just specialized MRIs that are able to give us this indirect measurement of brain activity in real time. So advances like these have helped us to better understand how the brain works in chronic pain, which will hopefully prove to be helpful in trying to understand why some patients can seem to, have pain that occurs without an actual root cause, or why other patients continue to experience pain long after the pain stimulus has been removed. So imaging like this hopefully will give us insight and help us to pinpoint specific regions of the brain that can be activated in pain, and hopefully all of this research and these new ways of looking at the brain will help to develop new treatments and technologies for the treatment of this very complex condition.
Yeah, chronic pain is very complex, and it's interesting. I think with a lot of acute pain issues, it's pretty easy to identify a one or two root cause issue and ideally address it, right? If it's not severe enough, and correct it, and it doesn't transition into that 3 month plus chronic pain thing where we're actually creating changes in the nervous system, right? So when it does become now chronic, we see that there's not only the physical cause, we see that there's the nervous system changes, but then there's obviously some emotional causes that, when someone's having chronic pain, it certainly is negatively impacting their quality of life and their ability to function. And really feel happy and thrive. You can't do that when you're chronically in pain. So it becomes very complex, and there is multi-layers at that point. And one thing that comes to me is really how amazing the nervous system is, and in general, our nervous system is really set up to help us thrive and function at a high level. For example, I remember learning in chiropractic school that really usually like 10% of the input into our spinal cord actually register in our brain as like pain or as a sensation. So in other words, in general, for a healthy person, we don't feel every single thing in our body, because then we really couldn't function, do anything else, right? Our nervous system, our brain would be overwhelmed with signals. So our nervous system actually helps to shut that down. And so only the most immediate and needed information actually gets to the brain so we can recognize it. So when we talk about chronic pain, that obviously that threshold's been crossed, and it's almost like it can't shut it off. It's like the faucet's on and it's still running.
I love that analogy. And that's, you're speaking exactly or directly to that neuromodulation, that brain's ability to either dial it down or dial it up. And so in chronic pain, unfortunately, the painful signals are really dialed up. Sometimes I use the analogy of pain signals, hoping to get the pain signals to look like a nice, calm countryside. But instead, sometimes they're really erratic and disorganized, almost like a busy, rush hour going to Manhattan on the George Washington Bridge. Those pain signals they're coming from everywhere. They're being, shooting from every which way. And oftentimes with some of our treatments, whether it be focus on the central nervous system or the peripheral nervous system, are really trying to calm down these signals. We're trying to organize them, calm them down, slow them down. And so in chronic pain, the brain and the body has learned to live in this very disorganized, chaotic type of pain signaling.
Yeah, and it's very complex, and there's still like so much we don't know, right, about the brain, about chronic pain, and that's why it's amazing that your practice is participating in a study specific to endometriosis that's actually helping to really understand that better, because then obviously better treatment will come from that. So, where was I going to go? So yeah, you have, these patients in your practice, and you're saying like 75% that have these chronic pain, pelvic pain conditions are getting relief, a series of like 3 injections done weekly. Is that the protocol?
Well, the series of injections, it's actually bilateral injections, and 3 of them, 3 bilateral injections. So it's a total of 6. But I do want to mention that, our protocol, our success is not just the injections alone. It's really a combination of many things. It's referring these patients to physical therapy, which has proven to just really be so impactful for our patients and their improvement and well-being. Pelvic floor pain can sometimes occur if the muscles of the pelvic floor are too tight, for example, or they're irritated. And so this is myofascial pelvic pain, right? So pelvic floor physical therapy can not only help with this muscular pain, but it can also help to relieve the pain with intercourse. Sometimes it can even help with urinary or fecal incontinence issues that can be caused by a pelvic floor dysfunction or spasming. So with pelvic floor physical therapy, therapist is using his or her hands to perform both external and internal manipulations to the pelvic floor via the rectum or vagina. It is really not just these injections. The 75% is really comprised of some of the other modalities that have been extremely, extremely helpful in getting my patients better. I sometimes will prescribe nerve modulating medications to try to help with nerve pain that they're describing. And sometimes also, again, I'm referring my patients to cognitive behavioral therapy, by a trained mental health professional. It's a way to really address the negative thoughts and behaviors that are sometimes surrounded by this painful process. And this type of therapy can actually change the brain's response that is worsening the pain. So it's essentially, like we were speaking about, a way to retrain the brain, retrain the way that your brain responds to pain.
Yeah. And I have to say, I would definitely throw chiropractic in there too. You
Oh,
know,
100%. Chiropractic is 100%. I refer to chiropractic multiple times a week, actually, for my patients. I refer to yoga. I refer to acupuncture. So I guess my point is that it's not just what we're doing alone. It's the whole picture. It's the whole picture of all of us kind of working really hard towards getting these patients better with their pelvic
that
pain.
makes sense, especially with the chronic. Yeah, it's really a team approach and working
It's a team
at
approach.
at a
Yeah,
physical
absolutely.
and emotional level and multiple ways. I love that. That makes so much sense. So,
It does, and as the more chronic, sorry to interrupt, Lauren, the more chronic the pain, the harder it is to get them out of this pain process. So it really is going to take exactly.
so I'm sure you probably have had some patients come into your practice with chronic pain that are addicted to opiates. Like that's got to be a really challenging patient to help and support. What do you do in those cases?
Hmm. So far, I actually have not had really any patients that have been addicted to opiates. But yeah, I really haven't. But really, the research studies have shown that opiates are just not they're just not effective in chronic pelvic pain. They just don't have good efficacy. So we really stay away from those medications really for that reason. And so we use other medications, those nerve modulating medications that I was discussing. Sometimes we use muscle relaxants, really a hodgepodge of medications to try to get our patients better. Really, just try to look at what their symptoms are and just base what I'm going to prescribe on their very specific symptoms. There's no real formula per se. It's really more of an art and just trying to figure out what would best help those
Yeah,
patients.
it's very individualized. You have to be, right? Because even two women, let's say presenting with endometriosis, can really need two different treatment plans. Do you have like maybe a case study of a success story from your practice with a woman with chronic pelvic pain who has done different modalities and come out on the other end, really, resolved over that issue?
Yeah, I mean, so my colleagues continue and myself, we continue to try to continue to, record these case studies of patients who've really shown good improvement with these with the protocol. But I would say I have plenty of patients that I can just speak to on a personal level that have come to me with 20, 30 years worth of chronic pelvic pain. And so they'll come. This one patient in particular that I'm thinking of, she had chronic pelvic pain for 21 years. Went through the protocol of again medication management, um, injection series, pelvic physical therapy, and chiropractic, and she did extremely well on the other side. And now she actually came in not being able to sit for more than 20 minutes without excruciating pain. And she actually works at a job where she needs to sit. So it was affecting her financially. She wasn't able to provide for her family because of it. And now she's able to sit for more than 7, 8 hours without pain. She was able to get back to her running routine. And so I'm seeing more and more of stories like this where patients are able to reclaim their lives and just really get back to a more functional place.
That's beautiful, Melanie. So, I mean, my mind's just blown that this woman had these symptoms for 21 years. And I'm just trying to imagine maybe how many other practitioners she saw prior to you and how she wasn't given any sort of relief or support. It makes me very sad.
It's a long time. 21 years is a long time. And of course, I will say that the pain it exacerbated over time. So it started off as, some recurrent yeast infections in her 20s, and she began to have some pelvic pain in association with the yeast infections and went on medications for those, and just this became her way of life. She began to learn how to live in this chronicity of pain, and 10 or 15 years later it heightened after she had her children. Then she had about 3 children, and the pain became worse, and just continue to heighten over time. And by the time they come to me, the patients, unfortunately, the pain has become so debilitating that, sometimes they're just standing up when I'm walking into the room because they're not able to even, sit and wait for me to come in. So that's an extreme case, but a lot of the patients that we do have at least 10 years worth of this chronic pelvic pain.
Wow. And so, for example, this one case study that you just shared, once she saw you, how many months of therapy and medication was required to help her get out of chronic pain?
Okay, so she actually required about 4 months, which is actually this. I'm mentioning this story because it's really a success story. It makes me very happy as well to share it. Sometimes it does take a little bit longer than that, but her body did respond very, very quickly to the modalities and to physical therapy. And I think what made her case so successful, a part of what made it so successful, is that she was very, very compliant with doing her exercises, her home exercises. She would go and get her manipulations regularly. She would take her medications very regularly. She really wanted to be better, like most of my patients do. And so she really was able to put in the work with us. It's really a team approach, not only just a team approach with the other practitioners, but it is a team approach with myself and my patients. We're working on this together. And so she was really a team player with me, and we got her better.
I'm really glad you mentioned that, because I was going to ask about that, and just, because I see that in my own office, like the patient, there is an active care required for patients to heal their bodies, and knowing the healing always occurs within, but it does require a lot of home care. I would say even anti-inflammatory diet, there's a lot of supplements that can help with inflammation, and certainly positive mindset. There's a lot that you can do with your lifestyle that can support your body's healing, in addition to all the practitioners that you're working with. And when you put it all together, you're going to see better, faster results. And, for 21 years of chronic pain, 4 months is a pretty quick turnaround. So that really, to me, speaks to how committed she was to her treatment plan.
She was very, very committed. And, I will say that she still has days where her pelvic pain can sometimes flare a bit, but in comparison to where she was when she first walked in, she's doing a whole lot better. She's a whole lot more functional, and she just continues to do the work. I think that it's, empowering for patients to know, to your point, that there are things that they can do to help propel the body's way of getting itself out of this inflammatory state. Like you said, diet is huge. Sometimes I refer my patients to nutritionists who can help them, guide them towards following this anti-inflammatory diet, avoiding gluten, dairy, processed foods. And that can be really extremely helpful in certain conditions that I treat. And patients, again, keeping up with their home exercises from pelvic, physical therapy. Acupuncture also is very, very helpful for these patients. And so the ones who keep up with going to acupuncture do better. Neuroscience actually explains why acupuncture is so helpful in this population. And the idea is that the acupuncturist treats these acupuncture points where nerves, muscles, and connective tissue can be stimulated. And then the stimulation is thought to increase blood flow, while at the same time triggers the activity of the body's natural painkillers. So it's very, very helpful. So it's the patient that, like you said, is trying all these different other modalities, working on their diet, working on stress levels, the emotional component, and keeping up with their exercise routine at home, and doing their stretching and deep breathing, imagery, to help with some of the emotional component. They do better.
Yeah, of
They
course.
definitely do better. Yeah.
That's inspiring. So as we were speaking, and you mentioned like a lot of your patients might be 10 plus years of chronic pain, I really want to speak to the women listening now who maybe aren't at that amount of time yet, but they are starting to develop these mild, these symptoms of pelvic, disorders, and maybe they recently just gave birth. And, let's speak about like why it would be helpful for them to not allow that to become their new normal, and how there is so much that we can do and ideally would be done sooner rather than later to prevent it from really cascading into that many-year pain syndrome.
Yes, no, absolutely. I definitely would love to speak to those women and say that there's hope, and there are many women that are experiencing exactly what you are experiencing. I can't tell you how many women that I see in the office that are surprised when I validate their pain and let them know that they are not the only ones. So I would like to say that there's definitely a lot of hope. We have many options, whether it be through medication management or more conservative measurements, to help to get them out of this pain process. And I would also like to mention that the sooner that they come and get evaluated, the easier it will be to get them to a place of function and to get them out of this pain.
Mm-hmm. It's so important to know. I have one patient in my office with endometriosis, and essentially what she was told by her doctor was, you'll just have to keep getting pregnant. She just had her second baby. Just have to keep getting pregnant to keep your symptoms at bay, because pregnancy and breastfeeding does minimize her symptoms. But obviously she's like, I don't really want more children. Like, she's like, I have 2 children.
Right.
She has a career. She loves her children, and she doesn't want to, like, in other words, to her, like, having more children isn't really the best way to manage her endometriosis symptoms.
Not a very sustainable way, right?
So it's important that women know this is, these options are out there. And sometimes, the advice coming from their OBGYN or other practitioners may not be what's the best fit for them. And so knowing that there are second opinions and other options available is the more you know what your options are, then the better you can make a better decision about how to best help your body heal.
I couldn't agree with you more. I could not agree more.
Yeah. So tell me about the practice you work for, where you're located, and so women can know, possibly physically coming to get care in the actual office.
Sure. So my practice is the Pelvic Rehabilitation Medicine. Their clinical headquarters is in Manhattan, and I work at the location in Englewood, New Jersey, in Bergen County. And we actually have many locations and continue to grow. We have one location on Long Island, one in Maryland, one in Michigan, and we continue to grow our practice.
In Miami now too, right?
In Miami as well. Yes, thank you. In Miami as well. And so, we're very easy to find. You can go right on our website, pelvicrehabilitationmedicine.com. And, you can find whatever location works best for you, what is more convenient. And we see patients, men and women, with pelvic pain of all sorts, all different etiologies. We have a specialist, an endometriosis surgeon on board. We have we have also a practitioner who treats different back conditions with interventional pain procedures. And we continue to build and grow our practice. And we see, again, both men and women with chronic pelvic pain.
So, Melanie, I'd love for you to just talk a little bit about men with pelvic pain, because we do have, even though most of the listeners are women, they have certainly husbands and partners in their lives that might also be experiencing pelvic pain. And we know that women are the leaders in the healthcare of their family. So maybe they could help direct their men to getting the care that they need as well.
Absolutely. So I see at this point about 20% of my patients are men, and they're coming in with really all types of symptoms. But a lot of these men are also coming in with this dyspareunia or this painful intercourse, painful sexual intercourse, as well as a lot of patients are coming in with abacterial or non-bacterial prostatitis, and then having symptoms that are mimicking prostatitis. Then when we actually take a closer look, they also have either they don't have prostatitis or they're having prostatitis concomitantly with pelvic floor dysfunction. So a lot of these men are coming in with this, urgency and frequency of urination, again, painful intercourse. Sometimes they're coming in with just this kind of spasming or tensing of the pelvic floor and don't know what to make of it. And so I can definitely help these men in trying to figure out what's going on, why they're having these symptoms, and if needed, I can get them to the appropriate practitioner if I'm not able to help them. But I do see a lot of these male patients with similar symptoms, and the protocol treating them with some of the things that we spoke of earlier in terms of medications, physical therapy, injections, acupuncture, chiropractic are extremely helpful in getting them back to function and quality of life as well.
Right. And I'm wondering in those cases, like sometimes possibly prostate cancer diagnosis might come up.
Absolutely. Absolutely. If those patients have not been evaluated and haven't had blood work or haven't had a prostate exam or haven't, had PSA drawn, we're making sure that we're referring them to the appropriate practitioner to make sure that that is ruled out as well. Really, when they come to me, it should be a diagnosis of, we're a diagnosis of exclusion, meaning they should have really ruled out, or I need to rule out some of those other things before we can come to the conclusion of it being from a muscle or a nerve.
Right.
Mm-hmm.
So for these men too, I'm assuming maybe it's been fairly chronic. It's been several years. And certainly, like you mentioned, their quality of life is very much impacted. And they're also sometimes getting the same type of injection you mentioned that the women receive.
Yes, oftentimes we're giving them the same type of injections. And oftentimes the injections that I give are also really individualized. I can do injections that also are targeting the nerves of the lower abdomen, which can help with urinary urgency and frequency as well. So sometimes I am adding on different types of blocks, hydrodissection blocks and trigger points to really be able to target their symptoms.
And what about if there was some trauma? I mean, we talked briefly about birth trauma with women, but what about with men? Like a sports injury or something.
Oh, yes, absolutely.
Yeah.
That's a great point. So I'm often finding sports hernias or inguinal hernias in these men. So it's not uncommon that they come in and they're having this groin pain along with their pelvic floor pain. And so I'm oftentimes getting imaging and picking up on some of these sports hernias in men that are oftentimes huge culprits in terms of the cause or partially of the cause of their pain. So that's actually a huge one for men that, we're doing a lot of imaging and picking those up too.
And then you're referring out for surgery?
Exactly. If they're surgical candidates, if there's any concern of, necrosed bowel, absolutely. Sometimes even if it's just a fat hernia that can be surgically repaired. And sometimes that's all it takes for their pain to go away.
Mm-hmm. That's really good. It's good to know. So I think this is important. Like a lot of times when we think of pelvic PT and pelvic pain, and we really think it very like a woman specific issue, but men have pelvises too, and they
Men
have
have
pelvic
pelvises.
floors, and they certainly have their own conditions and challenges, without having a uterus.
Exactly. You couldn't be more right. And there's definitely such a gap in terms of men being able to be open and honest about their pain, and hopefully I think that is improving. But there are barriers for whatever reason. There's social barriers that prevent these men from feeling that they can come and speak about these things. And so a lot of my visit is really, again, validating their pain, helping them to understand that they are not alone in this, that I see plenty of other men, and that there is a light at the end of the tunnel, and that we can get them, if I'm not the appropriate practitioner for what they need, that I'll get them to the appropriate practitioner, and that there's definitely a lot of hope.
And I think, what I'm really wanting to reiterate, and that I just heard from you, is that there's maybe in our culture for men and women, there's shame around chronic pain, especially in this part of the body. Then for some patients, they might be told that it's psychosomatic only, it's only in your head. And then if you feel hopeless and you feel like there's nothing you can do, and it's hard to speak up for yourself. And so I'm really wanting our listeners to know that, even if for chronic pain, there might be an emotional component, it doesn't mean that it's only emotional, and there can be so much more support brought in to help your body heal physically and emotionally, when you trust your intuition that, there's something else going on, and get a second opinion and really speak up for yourself.
I think, I think that's an amazing point, and I'm so glad that you brought that up, because so many of my patients really have been told that it's all in their heads. And so, yes, it's true that your emotional state can very much affect what's happening physically, but that doesn't negate what's actually happening physically. So absolutely, these patients are going through real pain, and it's coming from a real physiological process. And they need help. They need help, and we're here really to help all of our patients get to a better place.
Mm-hmm. I love it. Well, Dr. Howell, I'm so grateful for you to take the time to come on the show today, share your advice and wisdom, and really, I think at the bottom line here is that we want to share and spread hope for men and women that are suffering from chronic pain in their pelvic area, that there is hope available and solutions.
I thank you so much for having me, and it's really an honor to treat these patients. And thank you again for the opportunity to speak to them.
Thank you.